So with that, Dr. Karasik and I think we'll take some questions.
Is there any pancreatic tumor benign or all is cancerous?
There are a few that are benign, but the predominant, the most common is the adenocarcinoma, the aggressive pancreatic cancer. So benign pancreatic tumor are very, very rare.
So through the screening, so if someone, warrants screening, that would be looking for the cysts early on, or I don't understand what that really means.
It's looking for a precancerous state, and cysts are one of them. But sometimes you find a solid tumor just at a much earlier age. And so still there's a much better chance of having cure.
Now, what about age-wise of if somebody has the high risk? I mean, are you talking about young children being tested? Or
Well, in part it depends upon what the age of the youngest first-degree relative that had cancer was. So, for example, if somebody had pancreatic cancer, this actually works for all kinds of cancers. Cancer at age 40, we start screening at least 10 years earlier in the kids. Now, if they were to smoke, you'd want to start even 10 years earlier, but you'd really want to beat up on them for that.
Absolutely.
Can you live without pancreas?
You can. You'd be a diabetic. So you can, but we can give insulin, and we can give the enzymes by mouth. It's not as good as having a pancreas, but absolutely you can live very good lives. But it's going to be a lot more work being a diabetic.
It's much easier to live day to day and not have to worry about how much insulin to give or how much enzymes to take, because when your pancreas is working normally, it does all the sensing and thinking for you. But there is life without a pancreas. Dr. Karasik and I both manage several patients, and it's really, is it better to live without a pancreas or to not live very long with pancreatic cancer? And when you really weigh those things, it is certainly a challenge, particularly the diabetes. And that's why I make sure everybody's counseled by an endocrinologist ahead of time. They have to know what they're getting into. And so being well prepared is certainly a big part of it. But it beats pancreatic cancer every time.
I was just wondering if in time people were screened, like we get the colonoscopies, and if you deemed necessary to have the endoscopic ultrasound, would it be, do you think, like a 5-year, 3 to 5 years come back? Would it be that time block?
No.
No.
First of all, it'll never be screening like with colon cancer, which is a much more common cancer. And the rate of progression is much more predictable. It takes 7 to 9 years for a polyp to develop into a cancer. It's easily identified and easily removed. And even endoscopic ultrasound, it's very difficult to see these things. And the high-risk groups, and you can only really screen high-risk groups. If it wasn't for the fact that colon cancer was so prevalent, there wouldn't be any screening for that. But this is a much less common, in the absence of high-risk, genetic syndromes, much less common tumor, and so it'll never be like that I can imagine.
Have there been any conclusive studies showing that untreated gallbladder disease could have caused pancreatic cancer?
Not that I'm aware of.
No. Gallbladder disease.
So that it inflamed the biliary ducts and it could cause inflammation.
Well, chronic inflammation in any organ increases the risk of cancer in that organ. You're probably, there's something going on right now trying to educate the public on chronic reflux, because it's resulting in a rapid rate of esophageal cancer. The same thing with chronic hepatitis and liver cancer. Chronic pancreatitis we talked about, and pancreatic cancer. Chronic inflammation of the gallbladder can increase the risk of gallbladder cancer. There's no doubt about that. And chronic inflammation of the bile duct, and there are situations, can increase the risk of bile duct cancer. There have been some epidemiologic studies that I've read about, talking about increased risks of pancreatic cancer when someone's had their gallbladder out, not when they have inflammation, when their gallbladder is out, and when they've had a partial removal of their stomach. And it's been hypothesized it may be because of increased hormone levels, CCK. But that is not clearly shown, and I have never personally seen a relationship between gallbladder disease and pancreatic cancer.
Well, so my dad died from pancreatic cancer, and that's when he was operated on to take his gallstones out. His gallbladder was shot, and that's when they saw it.
Yeah, that's when they saw it. And the reason that's when they saw it, and I'm sorry for your loss, but the reason they saw it is because there was no symptoms previously. They had not looked. And there was no reason to have looked.
Let it go for years, gallbladder.
But the gallbladder was not responsible for his pancreatic cancer.
No, it gets enlarged due to the pancreatic cancer developing, and so it can become a potential target to be evaluated because of the cancer growing. But it's not the cause. It gets bigger as a secondary.
Gallbladder disease is very common, very, very common. Pancreatic cancer is not.
Well, aside from the ultrasound, are we close to a blood test screening? Like, I know they had CA-125 was probably an old test now, but is it just too many false positives or negatives, or?
Yeah, there's not been one found that can really help with identifying pancreatic cancer. There are a few that become elevated once a cancer's there, particularly if someone's jaundiced, but to really adequately screen, you want to have one that's sensitive years in advance, and we're not there. But there's a lot of study in looking at those, as well as some stool studies and various other factors. There is some work being done and research being done, but there's not one there yet.
And there are people looking at actually the genes in the fluid that the pancreas puts into the intestine. Actually looking for genetic abnormalities that might suggest that here's somebody who has pancreatic cancer, but nothing so simple as a blood test, at least not yet.
I think something just came out this past week from a company I follow. It's differentiating between disease and cancer.
There's something in the news
Just this
about.
past week, so I don't know.
I don't know any details about that. but
I don't know what that was, but it's,
That's what the headline was.
yeah, I will tell you that that's probably, there may be a role for that, but I'm sure it's not a panacea. The way it works with a lot of these things is that, for example, the pancreatic cysts, there are different genetic markers that might, with increasing accuracy, tell you whether something is a particular cyst, but it won't tell you about all of them. You'd have to use a different marker for each one. I don't know exactly what you're talking about, but do you know the name of it?
Clidizumab-based blood test can differentiate between pancreatic cancer and chronic pancreatitis.
I haven't seen that study, but I will
April
certainly
8th.
look at that.
So that's even 2 days ago, April 8th.
You're ahead of me. Am I out of a job?
No, I just, I have a vested interest in that, trying to figure that out.
I just came
I don't
back.
know anything.
I just came back from a conference involving this kind of stuff at Johns Hopkins, and I can tell you they are one of the leaders in looking at these kinds of things. We're not as close as that title would imply.
Yeah. That's what I'm trying to understand.
Could you review again, please, the relationship between some polyp syndrome and pancreatic cancer?
Oh, colonic polyposis syndromes? There's something called Putz-Jaeger syndrome. It's very rare. There is HNPCC, the Lynch syndromes. They also have polyposis and increased risk of pancreatic cancer.
What are those syndromes? Could you just
Well,
in layman's terms?
these are autosomal dominant syndromes, which means you get one of the gene, everything comes in pairs. You get one from the mother and one from the father. And if either one passes on the bad gene, the disease is there. With Putz-Jaeger syndrome, they have some classic findings of beauty marks basically, little on their lips, on all their mucous membranes. With the Lynch syndromes, the way we're picking those up these days is there are certain familial inheritances. So when you look at people who have many different cancers, or particularly colon cancers on the right side of the colon, or multiple colon cancer. I just saw someone the other day had his third separate colon cancer over 10 years. Each one was cured and he developed a new one. Those are people we have to think about Lynch syndromes. But I couldn't look at someone and say, except for these little pigments, I wouldn't be able to look at someone and say, here's a person who has that syndrome.
Okay, but for example, an analysis of a polyp would reveal that.
Well, if you analyzed a colon cancer, you would, with Lynch syndromes, you'd see something called microsatellite instability. That would be very helpful. But Peutz-Jeghers syndrome, no, you'd not be able to. There's a particular type of polyp that you get, but you don't have to have that syndrome in order to have that polyp.
Are there any laboratory tests that would alert you to a potential problem brewing?
Not early on. If the tumor grows, like Dr. Kirsch was saying, by the bile duct, it causes jaundice, well then you're going to have those abnormalities. But short of reaching that size, you're not. That's one of the problems. Occasionally I'll see somebody, probably the best results I ever had is someone who had a pancreatic cancer. Lived 7 years without evidence of disease. He recently died. And he was referred to me, not because of any extra risk, but because there were some abnormal pancreatic enzymes. Usually there are no abnormal pancreatic enzymes, and his were very subtle. And I must say I wasn't all that impressed with him, but his doctor pushed me to do it, and lo and behold,
Found something.
there was a very small tumor. But the answer is no. There are no particular blood tests.
So I just kind of want to follow up on her point in terms of screening and recommendations for our siblings or our children. Should they start to, if I had it, or I do have it, should we be telling siblings go get screened if they're first degree, or look for other?
At what age did it develop?
They just found it at 47.
47. In general, most people are saying less than 40 is really where you start screening. 40 to 45. Are there other cancers in your family?
My dad had pancreatic cancer.
Okay, so now we have 2 generations. So the answer is I would say
They should be
yes.
screened.
But,
They should be
but-
screened.
So there's some.
And
yeah.
10 years, starting 10 years earlier than when you developed it.
So I should be telling I'm one of 8, so I should be telling my siblings
Get screened.
to start getting screened.
And they should get it by endoscopic ultrasound.
Besides the Whipple procedure, what other kind of operations do they do? Because I saw something on TV a few years ago
Mhm.
on Island. They were doing some kind of strange, like, looked like a knife or a gamma ray or.
As far as surgical operations, the Whipple is the predominant one, and that's based on the location within the pancreas. So the head and uncinate, that requires the Whipple. The distal pancreatectomy, the body and tail, is for the other side. There are, different types of radiation. There are certainly focused. The gamma knife is one of those it's used to kill tumors where they are. In people that cannot have an operation or have other issues that just can't undergo surgery. But the gold standard's still surgery. But as far as focused radiation, it's one of those things that in certain people it can be used, but it's not the magic bullet.
One on the slide, you said that, the symptom, one is jaundice and the back pain for the pancreatic cancer.
Jaundice is one of the most common signs because the bile duct gets compressed.
And then how you look into the jaundice?
Well, you see it, the yellowing of the eyes, the yellowing of the skin, becomes quite obvious. The blood work reflects that the bile is not getting to the intestine, and that backup causes the liver enzymes and the bilirubin to be elevated in the blood. The evaluation for that involves looking at the gallbladder, looking for gallstones, but also looking at the bile duct to see where the blockage exists. And that very often then leads to looking into imaging studies, and often endoscopic ultrasound and some other endoscopic studies to try to determine if it's a stone issue in the bile duct or if it's the more concerning bile duct or pancreatic cancer issues.
For the Asian, our skin color is kind of a little bit yellowish. And so do you think that we should look at the eye first for the first sign?
Well, even
For the jaundice?
Even in people of Asian descent, jaundice is much different than the skin color. And it does certainly, as you said, involve the whites of the eyes turning dramatically yellow.
But the whites of the eyes always turn yellow before the skin turns yellow, regardless of your ethnicity. And the urine becomes dark like tea or Coca-Cola before the skin.
Yeah.
Okay, thank you.
Go ahead.
Are there symptoms for the pancreatitis?
Pancreatitis? Pancreatitis in most people results in pain. It can be intermittent though. Pain in the belly. Pain in the belly. There can be a chronic smoldering pancreatitis where you don't actually have symptoms until it's very late, in which case you start having loss of function. So you start becoming a diabetic because you start destroying cells that make insulin, destroying the mechanisms that put the enzymes for digestion into the intestine. And so diarrhea develops, and there's a lot of fat in there, so people lose weight. But early on, there may not be any symptoms, but usually there's always at least one or more bouts of pain, severe pain.
When you say lose the weight, sometimes the weight can be fractured a little bit. If you pound up and down, depending on how different
Yeah,
you are.
this is an uncommon thing. I mean, people gain and lose weight all the time. I'm talking about people who lose weight despite and continue to lose weight despite eating a normal amount.
So for how extended time, like you would say 6 months, 3 months, for 10% or 20% of the weight?
Well, if you have any medical change for 3 months and there's no explanation, it's worthy of seeing your physician, certainly. Or if you lose a lot of weight in even a shorter period of time, any dramatic change, I would recommend you see your physician. But I don't want you to walk away saying every time somebody loses weight, that means it's pancreatic cancer. That's
No.
That's not the case.
That's
There's
why-
so many different reasons for losing weight that are much more likely. This is not that common a problem.
Yeah, I think come to the seminar is good, but on the other hand, I don't want to become paranoid. That's
Right.
why.
And I don't want you to.
That's why that.
But that's why you have-
some question of some
Yeah. You
finite.
you have to have, no, I would rather than you walk away being able to make the diagnosis, I would rather you have a relationship with a physician that you can go to and say, this is what I'm feeling, doesn't mean anything. So often these days, I'm having patients who have access to, via Google and everything else, that come to educate me on what's going on, and they've scared themselves to death.
That's right.
I would rather you have a relationship with a doctor that you trust, or if you don't trust yours, find one that you would, and then go to that person if you're having a problem. And let them try and figure it out.
And get your regular checkups.
And I just want to take a second and say I've had a great experience with Hartford Hospital. It's not you two in particular, it's your colleagues, but you are all together, so it's unbelievable.
That's great.
So I would really one of the things that we found a little bit challenging is that communication or education of the general practitioner. And is there anything we can do to facilitate that type of, because we check in now with check in with the general practitioner now, right? I don't think we're covered to continue that relationship with your organization, is that correct?
Post-surgery.
Post-surgery?
I would think you'd be following us forever.
No,
Or we'd be following you forever.
We tend to try to follow somebody after an operation every 3 to 4 months. You know, myself as a surgeon and the oncologist that's working with the person, because again, surgery alone is typically not the cure.
And is that covered, or is that,
Mhm.
who pays the cost of that?
Well, the
The insurance
covers
companies.
that.
Yep.
But
I think he's also talking about just in
That's it.
terms of his general practitioner, getting the feedback from the surgeon and his other specialist, that piece of it. Like the
Mhm.
third person doesn't seem to be as involved.
um,
The person who
I-
he sees for other things.
I have to admit that communication is not always as good as we would like. We're constantly trying to do better. I
Is there
have.
a way we can help it
Yeah.
though?
Yeah, well, that's a very good question. I carry Dr. Curtis's phone number in my phone. We call each other all day long, but I don't have every primary care doctor's
Right.
number in my.
There's so many of them.
Right. When I do a procedure, the procedure note is automatically sent to them. But you're right, when updates occur, things occur, you know, we, and I'm speaking for all of us physicians, do need to do better. And the whole electronic health record is supposed to help with that. I find maybe it's helping a little bit, I don't know. It's making my life a lot worse, but in time when they're all synced, which doesn't happen now. There's different companies making these things. They don't talk to each other, the same as physicians didn't talk to each other. But ultimately they will. Then everybody's going to be on the same page all the time. But I would recommend to you, if anything, you know, when you're seeing your doctor, say, please make sure my primary, I mean, you shouldn't have to do that, but please make sure my primary doctor knows about this encounter, you know, what happened.
Because we do try to make sure they're involved.
Yeah, and this is about us facilitating the conversation, what
Right.
our expectations should be. It's not at all any type of negative.
Right.
No, I'm not
Trying to
taking it that way.
understand what the expectations are.
It's a very good point, and it's a tough time to learn how to use the healthcare system. I would recommend if you ever have a problem or a worry in that regard, you ask your doctor at that time, what should I expect? You know, as far as the interplay amongst physicians, you know, when I should utilize these resources, when I should call. You ask any question that comes to mind.
Okay, I've got one more question about symptoms. Back pain, you always hear association. If there is an obvious symptom of pancreatic cancer, what type of back pain and where?
So, you know, back pain is such a, those are more surgical questions.
I don't think so.
Back pain is such a common problem.
It's new back pain.
Yeah.
Kind of new back pain that's different from what's been before.
It doesn't get better when you're laying on your back necessarily. Oftentimes pancreatic pain will get better when you're crunched up in a ball, but not always. They don't always obey all these rules. But I wouldn't look at back pain in the general population and say, aha, we have to look for pancreatic cancer.
No, that's not what I'm suggesting. I had a mother that had pancreatic cancer, my father had colon cancer. And so obviously one
No,
becomes a little
I
more
understand.
aware of,
But there is
sensitive to-
But there is no type of back pain that I could tell you such that you'd walk away knowing, aha, I don't have that, I do have this. You know what I mean? Okay, well, thank you very much.
Thank you for coming out.